Welcome to Dr. Balaga's podcast for the Curious Doc. Today is 1st July 2026. This video is on an AHA, ACC, ESC World Heart Federation Expert Consensus document. It's the second Universal Definition of Heart Failure 2026, published online 2 days ago, 29 June 2026. Why was a second universal definition of heart failure needed? Because ambiguity in heart failure and antecedent stages has limited research, surveillance, prevention, and consistent care. What does the document aim to standardize? It standardizes terminology for clinicians, researchers, health systems, and policymakers. What changed in phenotype classification? The framework moves away from rigid left ventricular ejection fraction cutoffs towards reduced, preserved, and improved ejection fraction groups. What new classification is proposed? A universal classification of heart failure causes is proposed to support standardized clinical and research reporting. What broader issues does the document emphasize? It emphasizes dynamic heart failure trajectories, social determinants, geographic variation, prevention, early detection, and global equity. Definition of heart failure syndrome. How is heart failure defined? Heart failure is a clinical syndrome caused by structural or functional cardiac abnormality with symptoms, signs, and supportive laboratory or imaging findings. What symptoms and signs support the diagnosis? Shortness of breath and exertion, orthopnea, jugular venous distension, crackles, S3 gallop, and abdominal or leg swelling are typical. What tests increase diagnostic certainty? Elevated natriuretic peptides or imaging evidence of congestion, and elevated intracardiac filling pressures increase certainty. Can one test alone define heart failure? No. Diagnosis rests on accumulation of suggestive features within a comprehensive clinical assessment. Why is imaging important when heart failure is suspected? Imaging evaluates structural and functional abnormalities, informs cause, and helps guide therapeutic approaches. Permanence of the diagnosis or condition. Is symptomatic heart failure considered a permanent diagnosis? Generally, yes. Once established, the diagnosis usually remains even if clinical condition improves with therapy. Why is ejection fraction alone limited? Ejection fraction thresholds are imperfect because values vary by modality, patient characteristics, and response to therapy. What does improved ejection fraction signify? Indicates prior reduced ejection fraction that has increased over time, usually after treatment. Does improved ejection fraction eliminate risk? No. Patients may still have structural abnormalities, biomarkers, symptoms, or future heart failure events. How should trajectory influence care? Trajectory should inform prognosis and the individualized approach to GDMT or guideline-directed medical therapy. Definition and criteria of stages of heart failure. What is stage A heart failure risk? Stage A includes people at risk without symptoms, structural cardiac changes, or elevated cardiac biomarkers. Who belongs in stage A? Example, high blood pressure, hypertension, atherosclerotic disease, congenital heart disease, diabetes, obesity, cardiotoxin exposure, family history, or genetic risk. What is pre-heart failure or stage B? Stage B includes no symptoms but structural abnormality, abnormal function, elevated natriuretic peptides, or elevated troponin. What defines stage C? Stage C includes current or prior symptoms or signs of heart failure caused by structural or functional cardiac abnormality. What defines stage D? Stage D includes severe symptoms at rest or minimal exertion, recurrent hospitalizations, intolerance or refractoriness to therapy, or the need for advanced care. Risk reduction across stages. Why emphasize stages A and B? Most people are outside symptomatic stages, so prevention and early detection are central to reducing heart failure burden. Which social factors affect heart failure risk? Poverty, limited education, neighborhood deprivation, and cumulative social vulnerability affect incident heart failure and prognosis. Which cardiometabolic risks deserve attention? Overweight, obesity, chronic kidney disease, and diabetes are increasing globally and offer prevention opportunities. Which therapies may lower new heart failure risk in stage A? Antihypertensives, obesity and diabetes therapies, SGLT2 inhibitors, glucagon-like 1 peptide receptor agonist, GLP-1 agonist, and finerenone in CKD with diabetes may help. What emerging tools may aid screening? Natriuretic peptides, troponin, urine albumin creatinine ratio, AI-enabled ECG may identify higher risk patients. Phenotypes of heart failure. How has heart failure phenotype traditionally classified? Classification traditionally relied on LVEF and etiology. Why do phenotypes matter clinically? They guide diagnosis, treatment selection, prognosis, trial interpretation, and targeted therapy. How has newer tools changed phenotyping? Advanced imaging and wider genetic testing have expanded recognition of diverse cardiac phenotypes. Why are comorbidities important in phenotyping? Comorbid diseases and their therapies can shape phenotype and influence appropriate management. Why is accurate phenotype identification increasingly necessary? Therapies are increasingly phenotype specific, making correct classification clinically consequential. Classification of heart failure according to LVEF. Why has LVEF been central? It has anchored trial eligibility, therapy extrapolation, device decisions, and expected treatment response and monitoring. What limitations affect ejection fraction cutoffs? The cutoffs are arbitrary, the measurement varies, and interpretation differs by imaging modality, sex, age, and ethnicity. What is simplified 2026 grouping? Heart failure is grouped as reduced ejection fraction, preserved ejection fraction, and improved ejection fraction. Why avoid rigid numerical threshold? A flexible approach better accounts for clinical context and biological variation. How is improved EF framed? It reflects previously reduced LVEF and has increased or normalized. Classification of heart failure by cause. Why classify heart failure by cause? Identifying causes enables targeted diagnostic and therapeutic strategies beyond standard heart failure treatment. Why is ischemic versus non-ischemic inadequate? It overlooks multiple cardiomyopathies and treatable conditions that may alter prognosis and therapy. What example illustrates targeted treatment? Cardiac amyloidosis requires amyloidosis specific therapy in addition to conventional heart failure management. What does the universal cause framework support? It supports standardized reporting across clinical care, registries, clinical trials, and research. Is the cause framework tied to ejection fraction? No. Pathogenic classification is independent of LVEF. Proposed universal classification of heart failure by cause. What ischemic causes are listed? Ischemic heart disease, myocardial infarction, and coronary artery disease are listed. What pressure or valve causes are included? Hypertensive heart disease and structural valvular diseases, including rheumatic and non-rheumatic valve diseases. What rhythm causes are included? AFib, tachycardia, dysynchrony, PVCs, and RB pacing can cause cardiomyopathy. What infiltrative, inflammatory, infectious, and toxic causes are named? Amyloidosis, hemochromatosis, Fabry disease, myocarditis, Chagas disease, HIV, Lyme disease, autoimmune disease, sarcoidosis, drugs, alcohol, cocaine, and amphetamines are examples. Cardiotoxic chemotherapy is another example. What other groups are included? Heritable, pericardial, metabolic, nutritional, pregnancy-related, stress-induced, pulmonary, congenital, high output, other systemic, and idiopathic causes are included. Geographic variation. Why does geography matter in heart failure? Causes, presentation, management, and outcomes vary substantially across regions and income settings. How does migration affect clinical practice? Clinicians in host countries may encounter rheumatic heart disease, Chagas disease, endomyocardial fibrosis, TB pericarditis, or peripartum cardiomyopathy. How does ischemic heart disease contribution vary? It exceeds 50% in some high-income and European regions, but is less than 10% in sub-Saharan Africa. Which regional patterns are highlighted? Lean diabetic preserved ejection fraction in Southeast Asia, Chagas disease in Latin America, hypertensive or peripartum disease in Africa. What evidence gap remains? High-quality data on prevalence, causes, and outcomes remains scarce in many low and middle-income countries. What is worsening heart failure? It is progressive deterioration in symptoms, signs, and quality of life in person with prior heart failure. Does worsening heart failure include new onset heart failure? No, it requires a prior heart failure diagnosis and excludes new onset cases. What manifestations may occur? Shortness of breath, edema, malignant arrhythmias, reduced exercise capacity, elevated pulmonary pressures, ventricular dysfunction, and higher biomarkers may occur. Are hospital visits required for diagnosis? No. Unplanned visits or admissions are common but not required. What events are excluded? Worsening primarily caused by acute coronary syndrome, infection, or poor adherence is excluded from definition. Decompensated heart failure. What defines decompensated heart failure? It is heart failure requiring escalated care or rescue therapy, often during hospitalization. How does it differ from worsening heart failure? Worsening heart failure is a progression event. Decompensated heart failure is defined by treatment escalation. How may it present? It may develop gradually over days to weeks or acutely as pulmonary edema or cardiogenic shock. What treatment intensification may be needed? Higher diuretic dose, combination diuretics, implementation of guideline-directed therapy, that's GDMT, devices, valve intervention like TAVR, mechanical support, transplant, or palliation may be needed. Why is context important? Therapeutic escalation thresholds vary by regional practice and healthcare resource variability. Mode of presentation, acute presentations. What cardiovascular conditions can precipitate acute heart failure? Acute myocardial infarction, acute coronary syndrome, hypertensive emergency, cardiac arrhythmias, pulmonary embolism, and acute valvular disease can precipitate it. Can acute infarction-related heart failure resolve? Yes. Timely treatment may lead to recovery without chronic heart failure, although some patients progress. How can hypertensive emergencies present? They can cause acute left ventricular dysfunction, pulmonary edema, or both. What is arrhythmia-induced cardiomyopathy? It includes tachycardiomyopathy, atrial fibrillation-induced cardiomyopathy, and premature ventricular ectopic beat-induced cardiomyopathy. Can non-cardiovascular illness cause acute heart failure? Yes. Kidney injury, liver failure, or respiratory failure can produce volume overload and neurohormonal compensation with reversible symptoms after treating the cause. Mode of presentation for chronic presentation. How does chronic heart failure present? It often presents subacutely or indolently with gradual symptoms over weeks to months. Why subtle symptoms may appear? Fatigue, mild exertional dyspnea, and gradual weight gain from fluid retention may appear. Why is this diagnosis challenging? Symptoms may be mistaken for deconditioning or aging by patients and clinicians. What primary care pattern is described? Many patients receive chronic diuretics without a formal heart failure diagnosis. What screening strategy has trial support? Natriuretic peptide screening to improve identification of chronic heart failure in primary care. Heart failure mimics. They are conditions inconsistent with heart failure and not driven by myocardial neurohormonal activation. Why identify mimics? Misclassification can obscure the true cause of shortness of breath, edema, or exercise limitation. What approach is needed? A holistic assessment should distinguish true heart failure from mimics and coexisting conditions. Can mimics coexist with heart failure? Yes. Coronary disease, kidney disease, pregnancy, obesity, and deconditioning may coexist with or mimic heart failure. What tests can help separate mimics from heart failure? ECG, echocardiography, natriuretic peptides, cardiac imaging, and when needed, invasive hemodynamics can help. Coronary artery disease, heart failure mimics. How common is coronary artery disease in heart failure? Approximately half of the heart failure population across the ejection fraction spectrum has coronary artery disease. How can ischemia relate to heart failure? It may mimic heart failure, coexist with heart failure, or cause decompensated heart failure. Can chronic coronary syndrome present only as dyspnea? Yes. 10 to 15% report only existential dyspnea. How should coexistence be evaluated? Assess coronary likelihood with ECG and echocardiography, and then test for obstructive or non-obstructive disease as appropriate. Should heart failure algorithms be used? Yes. They help determine how much heart failure contributes to symptoms. Heart failure mimics chronic kidney disease and pregnancy. How can chronic kidney disease mimic heart failure? It may cause shortness of breath, exercise limitation, and edema from inadequate diuresis or disease progression. What cardiac abnormalities may accompany chronic kidney disease? Left atrial enlargement, LVH, diastolic dysfunction, and elevated biventricular filling pressures may occur. Why can pregnancy mimic heart failure? Shortness of breath, exercise limitation, and peripheral edema commonly occur in third trimester. How can myocardial causes be excluded in pregnancy? Natriuretic peptides and echo can help exclude myocardial disease. What pregnancy-related diagnosis must be considered? Peripartum cardiomyopathy or unmasking of pre-existing cardiomyopathy must be excluded. Obesity and deconditioning as a heart failure mimic. How do obesity and deconditioning mimic heart failure? They commonly cause shortness of breath, exertional intolerance, and peripheral edema. Why is physical exam less specific in obesity? Body habitus can reduce the specificity of congestion findings. How can natriuretic peptide mislead in obesity? They may be falsely normal even when preserved ejection fraction heart failure is present. When may invasive exercise hemodynamics be useful? It may be key when determining whether shortness of breath has a myocardial cause. What is the clinical caution? Do not dismiss dyspnea as weight or deconditioning without evaluating possible heart failure. In conclusion, what is the main contribution of this 2026 universal definition of heart failure? It defines stages, promotes early detection, emphasizes individualized risk reduction, and standardizes causes. What is the key advance in ejection fraction classification? The document moves from rigid cutoffs to clinically actionable groups across reduced, preserved, and improved ejection fraction. Why a trajectory is important? They show that improvement does not necessarily equal resolution, and that surveillance and tailored therapy remain necessary. Why address social and geographic variation? These factors shape heart failure risk, presentation, outcomes, and equity of care. What is the final clinical message? Use a standardized, cause-aware, trajectory-aware, and patient-contextual framework to improve detection, management, and outcomes. Read this fantastic ACC AHA, World Heart Federation document. It's available open access. Podcast brought to you by masterbedfacts.com. This podcast is for physicians and healthcare providers. If you enjoyed this video, please like, subscribe, and forward to your friends.